Hey everyone! This month, Light the Way is talking about health inequities in Canada. Now, most of us living here in Canada have heard in some way or another praise or positive acknowledgements about Canada's universal healthcare system. And rightly so. We are so blessed to be living in a country that prioritizes the health of its citizens. Our healthcare system is praised by experts and policymakers in countries like America, for example, as U.S. politicians have debated on how to fix their own system. But no healthcare system is perfect. Every system has its strengths and weaknesses. And here in Canada, it is important for us to not only be proud and aware of our strengths, but also our weak points, so that we may address them, learn from them, do better, and help create a system that works for all. Especially since right now, our hospitals are overburdened, we are under lockdown, and a stay-at-home order is in effect because of a global health crisis. Yes, it's true. Canadian residents have free access to physician and hospital services, no matter where we live, where we've immigrated from, or where we work. But access to this healthcare is a crucial sore spot in our system.
Before the COVID-19 pandemic, the Ontario healthcare systems were already under severe strain. Patients were waiting too long for care and specialized services, emergency department use was increasing, hospital systems were facing capacity pressures, and we did not have enough beds or equipment ready to face these capacity issues, let alone deal with long-term complex care needs. We were operating at full capacity, dealing with a persistent problem known as hallway healthcare. So COVID-19 is straining an already overburdened healthcare system. Long-term care facilities have been hit the hardest. As of August 2020, approximately 80% of all COVID-19 related deaths in Canada were linked to long-term care. The long-term care sector has been underfunded for decades now, and many facilities are overcrowded, have old infrastructure, poor ventilation, and severe understaffing. Confined group living situations can make physical distancing, good hygiene, and sanitary standards difficult to implement, thereby promoting the spread of COVID. This is also why Canada has seen a drastic number of cases amongst inmates in correctional facilities. More and more evidence is emerging to suggest that marginalized communities are experiencing high rates of COVID-19 infection. For example, those who go to homeless shelters or those without stable housing have difficulties accessing safe spaces to follow COVID-19 isolation rules.
Indigenous and remote communities also face high rates of infection because the virus is exacerbating pre-existing conditions. Conditions like limited access to clean water, lack of health professionals and services, higher prevalence of chronic diseases, and crowded living conditions are very common in Indigenous communities. Health inequities are well established in Indigenous populations in Canada. For example, there is a higher prevalence of high blood pressure, diabetes, and cardiovascular disease among First Nations people, and higher rates of asthma and COPD among Métis people. Canada has a history of systemic racism, colonization, and discrimination, and Indigenous people continue to live with the legacy of forced displacement, residential school experiences of abuse and neglect, and the disruption of traditional culture and practices. These are all traumas that continue to affect their bodies, spirit, health, and well-being.
This is why it is important to also think about the social determinants of health whenever we talk about healthcare. Canada lists the main determinants of health as income and social status, employment and working conditions, education and literacy, childhood experiences, physical environments, social supports and coping skills, healthy behaviors, access to health services, biology and genetic endowment, gender, culture, and race/racism. Social and economic policies, government structures and policymakers, and societal values and norms ultimately influence health inequities. These systems shape the way that power, money, and resources are distributed in society. Therefore, they influence our ability to control our health. And while we can't always see it, or sometimes we all turn a blind eye to it, stigma and discrimination are embedded in these systems and influence who has power and privilege. For example, a recent report by the BC government states that widespread Indigenous-specific stereotyping, racism, and discrimination exists in the BC healthcare system. Racist stereotypes that evolved from colonial beliefs paint Indigenous patients as quote-unquote less worthy of care, as drinkers and alcoholics, as drug seekers, bad parents, or as frequent flyers who are thought to be overusing the healthcare system. As a result of the stereotyping from frontline doctors, nurses, pharmacists, and social workers, Indigenous peoples experience harm, poor quality of care, and even death. When social services, long-term care facilities, and vulnerable communities are not given the proper attention, resources, and funding, people's health and well-being naturally suffers. Accumulating evidence supports the role of social and economic factors in determining COVID-19 outcomes. These relationships are complex and often intersecting, as a person's social conditions and access to healthcare impacts their risk of exposure to infection.
Earlier this month, we reached out to our community and asked if any healthcare workers or users have any stories or experiences to share. We asked them, have you ever felt small or powerless in a healthcare setting? What health gaps do you know of that you want more people to know about? If you work in healthcare, why do you do what you do? What does serving God through healing mean to you?
I came to Canada in the early 1980s as a fully trained and experienced nurse. I had the opportunity to work in different states in India, Jordan, and Saudi Arabia. As per government regulations, I had to write an English test and got permission to write the licensing exam. After I got my registration and license in the early 1990s, I could not find a job. And I attribute this to the fact that I am brown. My skin was not white. I struggled for 2 years to get a job. I finally got a job as a casual nurse, which meant that I had work if anyone called in sick, basically 3 to 4 days a month. I applied for jobs in all the Toronto hospitals, nursing homes, clinics, doctors' offices, etc. There was an internal post in the ICU, and I even took a specialization certificate course for 3 months. However, it was not given to me when I applied. The manager gave the job to 2 nurses who were newly graduated without the certificate for specializing in ICU nursing. I utilized the nurses' union to address the manager, but they could not give me a proper answer. I experienced a lot of frustration and disappointment. To keep a family going, one needs money. In this country, one person's income is not enough to run the family. Typically, the environments where I got casual work, I was the only brown person. Naturally, all other nurses kept a watch on me whether I was doing things okay or not. I felt small and powerless at times, as though all my years of nursing school and training meant nothing. I think now the situation changed for nurses because of COVID-19. Frontline and hospital staff are given respect and priorities, and lots of jobs are available. Sadly or luckily, I am retired now. The fact that people should know is discrimination persists in Canada. No matter what we do, what we say, and the people who come to Canada for a long time had many ill treatments since they migrated here. Serving God is crucial because He is the Almighty who heals. It is not just the doctors, because He is a great doctor in His own right. I believe I was serving God through my job. Nursing is a job in which the main motto is helping people in trouble, sickness, helplessness, and need. And when we do that, we serve God. If we do anything for a person who is in need, it is for God. God will bless us.
I work in oncology, so I feel powerless when I care for the young patients or parents with young children who have been diagnosed with cancer. It hurts to see them suffer and constantly question how long they have to spend with their families before they leave this earth. But it also makes me feel grateful that we live in Canada where money isn't always the reason a patient can't receive the best cancer treatment. On the flip side, you see how socioeconomic status can change a patient's trajectory. If the proper supports aren't in place at the beginning, it doesn't matter if you receive the best treatment. The mind is a powerful weapon in cancer, and a person's perspective and their mental status can also play a factor in the effectiveness of a treatment. For cancer, it's all about follow-ups and what happens at home. At the hospital, you're in a protected bubble where staff are always focused on you. At home, if you don't have the supports to ensure you're eating right, sleeping right, taking your medications on time, going to your appointments on time, your trajectory can change. Cancer is a lot to bear, and your mental health takes a hit. When your mental health declines, your need to take care of your cancer declines. And a lot of people forget that it's not just the treatment that can help someone's cancer prognosis, it's also about the supports in place after going home.
I've been working in social work for 14 years. I have been present when people have faced inequity in various environments. Healthcare is nothing new. I've gone to the hospital with women, sat with them, advocated for them while they've had panic attacks. A rule in our shelter was that anything to do with the brain and heart, shelter staff would need to send the person to the hospital, just in case it was a heart attack. A lot of the time, staff wouldn't accompany the client to the hospital. The dismissiveness of doctors and nurses alike have astounded me. Had I not been with them, it may have been worse, as I've heard stories of my clients that went to the hospital without me. My heart broke. I have felt the powerlessness and pain that the women would feel, and the dismissiveness of a doctor patronizingly telling a woman who experienced a panic attack, saying, well, it wasn't a heart attack. You're good to go home. Are you sure you didn't come here to get out of the house? Without even addressing the panic attack after sitting in the ER for 4 hours. Having to explain and fight with my manager that I'd stay longer than my shift as no one would come to relieve me, not understanding how scared this person was to be on their own in a sterile and cold place. Health gaps in how mental health is dealt with when it comes to vulnerable people are serious problems. As though a broken leg and a heart attack take precedence over a person who has had years of traumatic abuse and has doctors dismissing women coming to the ER for a mere panic attack, as opposed to taking mental health seriously that is rooted in trauma. Visits to the hospital further traumatize people instead of helping them through their healing process. I work in social work because this is God's work. I wouldn't have been happy or fulfilled in any other field. Healing has been an important journey of mine and for others. Since I began this work, as it goes in hand with the well-being of our society.
My first doctor was one that my mom used to take me to. I had no control since I was young, so not having a choice was ingrained in me. She was a doctor that I don't remember much about, but I felt I couldn't trust her giving me shots. She was West Indian and black like my parents. The mentality of beating children to get them to do what was wanted was warranted growing up in their time. This isn't the experience of all black West Indian people of that background, but my household was like that, and I learned how wrong it was. I had to do blood work, and instead of helping me calm down with growing anxieties of distrust, I was held down by my mother and staff while the doctor waited with dead expression. The commotion I caused in that office and the shame of having it broadcasted by my mother to the listening patients waiting outside for their turn had me sit still in that chair, traumatized. Some years had passed since I went to a doctor and I had to find a new one. All through high school, my period was really bad enough to send me to a hospital a few times because I would lose the ability to walk. So when I would feel it coming, I would stay home. I started my period in middle school and my first doctor prescribed birth control pills, but it made me more ill on top of the period pain and it lasted weeks. I explained all this to the new doctor. She checked me and arranged for me to go for an ultrasound. It was reported that they found nothing and to take Midol for the pain. But I couldn't stomach meds on my period, so I suffered. A month later, I went back complaining about the pain and how my legs would lose strength to hold me up, and the doctor's solution for me was to get pregnant. I was 19. The conversation was pretty much, do you have a boyfriend? Okay, for how long? Do you love him? Well, I suggest you get pregnant and you won't have to deal with that pain for a while. I was emotionally dead, thinking, am I not worth going to university? She didn't even ask if I'd planned to marry my boyfriend. There was no care of what I needed. I went for 2 more visits and never went back. I found a new clinical doctor close to where I was living. I thought I could trust her because she was black and younger than the first. She looked at me like I wasn't human and beneath her because her practice was in the part of the city where it was considered ghetto at the time. She had an air about her, so when I discussed my period problems with her, she interrogated me often if I was sexually active. I wasn't, and my ex-boyfriend was out of my life for 5 years. So after the tough and rough pap smear, I didn't go back. That encounter left me injured and not caring to find a doctor. So from 29 years old to 33, I saw no one. I was 34 and I had to find a doctor because I was really worried about my health. So I searched for one in the uptown core of the city, and found one who cared about my well-being. The assessment was to be done, but she emphasized that blood work would help to accurately assess my health. But there was no pressure, and she prescribed me an anti-anxiety pill to get it done if I chose to. I got it done, and I was believed when I said I was scared, and was comforted. Next, I had an ultrasound done, and the results said that I had cysts and fibroids. A change of diet greatly improved my pain, and I even went years painless. I've had CAT scans, MRIs, other tests done, all because she listened. She actually listened to what my concerns were. Growing up in a household where you don't matter, and with the immediate portrayal of black bodies, it was easy to think that the pain was in my head or I'm being a baby. So I settled on having little to no care. Some of us endure mistreatment because it's difficult mentally or geographically to find a doctor that takes on patients. My story is unique to me, but not uncommon in its parts. I really wonder if my life, or black lives, even mattered to care providers.
Thank you, Rachel Auntie, Faba, Ashley, and Lanessa for sharing your stories and perspectives with our community. All of your stories share one common thread: feeling isolated. Social inclusion does not usually ignite thoughts of health and wellness. Social inclusion is generally associated with how many friends someone has or where they tend to spend their time. But COVID-19 has made us all see the lived realities of what social exclusion can do to individuals and communities. From the perspective of an Indigenous single mother, being socially excluded can mean lacking access to emergency childcare when she has to stay up late at her job. An elderly senior in long-term care may go days without receiving any human interaction, and in some cases, personal support care. The gospel teaches us that Jesus was a healer, and he was a healer who was especially concerned about the social exclusion and isolation of the sick. When we ask ourselves, what is a healthy body? We can't limit our answers to just the physical body, because Jesus certainly did not. There are 7 dimensions of wellness: emotional, environmental, intellectual, occupational, physical, social, and spiritual. Jesus was concerned with healing not just physical bodies, but also emotional, mental, and spiritual bodies. The social inclusion processes that make up our lives have huge impacts on our health outcomes. These processes are influenced by social policies that govern us, which ultimately impacts our social determinants of health. So how can we influence our systems to bring equity to the forefront? And whose voices are left out in conversations around public health? As Christians, we need to ask ourselves the most important question: what would Jesus do?
The notion of sickness as reflective of one's value goes all the way back to biblical times. Sickness in Jesus' time was believed to be a product of personal or inherited sins against God, and sick and disabled people were routinely cast out, discriminated against, and refused entry into temples, not even to be touched or looked at throughout the Jewish scripture. This can be seen in Leviticus chapter 21, verse 18 to 20. No man who has any defect may come near. No man who is blind or lame, disfigured or deformed. No man with a crippled foot or hand, or who is a hunchback or a dwarf, or who has any eye defect, or who has festering or running sores or damaged genitals. This notion of sick people as quote-unquote polluting righteous people with sin even grew and extended to the racial and gender prejudices that the Jewish people showed. The Samaritans, for example, were not supposed to even walk on the same path as Jewish people. Not only in biblical times, but women all around the world even today are excluded from social and religious spaces due to beliefs that they are unclean because of their body's natural menstruation process. Thus, Jesus, a rabbi and a healer, sitting with and accepting water from a Samaritan woman, as we discussed in previous Light the Way seminars, was no less than revolutionary.
Most notably, Jesus healed people suffering from leprosy, a contagious long-term bacterial infection that leads to loss of feeling, senses, sometimes limbs, and sometimes death. Leprosy is usually caught by living with bad sanitation, poor living conditions, poverty, and malnutrition. This is shown in Luke chapter 17, verses 11 to 19. Now on his way to Jerusalem, Jesus traveled along the border between Samaria and Galilee. As he was going into a village, 10 men who had leprosy met him. They stood at a distance and called out in a loud voice, "Jesus, Master, have pity on us." When he saw them, he said, "Go, show yourselves to the priests." And as they went, they were cleansed. One of them, when he saw he was healed, came back, praising God in a loud voice. He threw himself at Jesus' feet and thanked him, but he was a Samaritan. Jesus asked, "Were not all 10 cleansed? Where were the other 9? Has no one returned to give praise to God except this outcast?" Then he said to him, "Rise and go. Your faith has made you well."
Due to the horrors of the disease, lepers back then were seen as people cursed and made impure by God, as terrible sinners. This ritual impurity and the fear of contagiousness meant that infected people were cast out of the community, often becoming homeless and disowned by their loved ones. As such, poor people in general were increasingly treated with great suspicion, and by Jesus' time, possession of wealth and privilege had become linked to how, quote-unquote, pure and holy a person was in society's eyes. In touching each other, just like Jesus and the Samaritan woman, Jesus and the Samaritan leper both broke multiple Jewish purity laws. But overcome at having been treated as an equal and cured of his stigma, the Samaritan was saved by Jesus. Jesus pointed out that the discriminatory treatment of people based on their sickness, physical or mental ability, caste, creed, ethnicity, or gender was a corruption of God's commandments. Instead of recognizing sin as a sickness, the people treated sickness as a sin. Jesus strove to fight this by breaking such social barriers. This idea of sick people as unworthy of care seen amongst the people of Jesus' time is still reflected today in the way we talk about racialized people's health issues and their experiences with the healthcare system, especially Indigenous peoples.
Marginalized people's living conditions, including their sickness, poverty, hunger, and homelessness, are often blamed on their perceived personal moral failings or identity as members of outcast communities. The reality is that their poor living conditions are caused by circumstances like systemic poverty, discrimination, and personal or intergenerational traumas. As Christians, we must follow Christ's example and ensure that all marginalized people are given fair and equitable access to all healing spaces so that we may bring God's love to those who need Him most. If there is one group in Canada who lies at the intersection of many forms of discrimination, it is Indigenous women, who are more likely to be kidnapped, attacked, murdered, or forced into sex work than any other group in the country. Due to centuries of colonial violence, racial segregation, gender discrimination, and loss of culture and land in residential schools, Indigenous women across the country struggle to access even basic necessities. In ode to our special focus on inequities and healthcare this month, Light the Way is honored to launch our first ever virtual fundraiser for True North Aid's Moontime Sister program.
This is an Indigenous-led, all-volunteer collective helping Indigenous women and girls throughout Northern Canada access menstrual health products like tampons, pads, menstrual cups, and menstrual underwear that they cannot otherwise afford. As Moontime Sisters have particular emphasis on engaging with community groups, we feel as it is a great opportunity for our Malayali Christian youths to support women in escaping period poverty, social stigmas, and unsafe sanitary conditions. We aim to collect $500 in donations for Moontime Sisters this month, with donations of physical products themselves to MTS also always welcome. Thank you so much for joining us this month. Don't forget to subscribe and share this video. Follow us on Facebook and Instagram and send us an email with any questions, interests, or involvement you'd like to have. Let's have a conversation. What do you think about healthcare in Canada? May God bless you all, and just know that you too can help light the way for humanity.
Help us to be planted in you.